So, renal functioning. What's happening further? Well, here you have more pictures, and this particular picture, the kidney that you see here on your left, taking that little area, and I have blown it up. And this amplification here, well, let me set this up for you. I need you to go from top to bottom. Top to bottom. The top will be the superficial, so therefore that'll be the cortex. And then the bottom that you're seeing here, what is that? That's the medulla. Now, this is an entire pyramid that has been amplified, right? A pyramid. Be careful. A lot of words here begin with the letter P. They're all clinically relevant. Well, with the pyramid, down in the medulla, you have something called the papilla. Okay? Now, around the medulla and the papilla, what are you seeing there? What's at the very bottom at that point? You call that what? The collecting duct. And then you have the minor callus, major callus, and you have the pelvis. In other words, you're forming the ureter, aren't you? What's my point? Well, here, let's say that you have a patient who's a female. She's pregnant, and, wow, that's a lot of pressure on the urinary bladder. Tell me about the urethra. To begin with, tell me about the anatomy of a female urethra. Itty-bitty tiny. To begin with, it's tiny. On top of that, she's pregnant. The urethra is facing the external world like that. What is she susceptible to? In addition, let's say that there's increased glucose in the urine. You're making that urine mighty tasty for whom? Welcome to E. coli. Oh, boy. So what is that E. coli doing? It comes into urethra, a pregnant lady. Pass the urethra very, very quickly. So now you have a urinary tract infection. And what is she saying? I have to go to the bathroom a lot. Burning sensation, perhaps. Not a good thing. And what about this organism, E. coli? It's, mountain climbing. Up the urethra. You see that? Here comes E. coli coming up the urethra. That's always a pleasant picture. Coming into urinary bladder. Uh-oh, I have cystitis. Are we done? No. We're going to keep climbing. Climbing where? Up the ureter. You're going to climb up the ureter. What kind of infection is this now? Ascending. Are you seeing the difference between the names? Urethritis, cystitis. I'm going to move up the ureter. Keep going. Keep going. What did I hit? Now, your female patient is saying, ouch, I have pain in my back. Flank is what it's called, okay? In addition, she might have a little bit of a fever, and she has to go to the bathroom a lot. Lots of urination. This is pyelonephritis. So what's my point? Well, where am I? I just ascended up my ureter. Where are you in this pyramid? Good, the medulla. I just call that what? The papillary, or the papilla. So therefore, E. coli is coming up, and comes up the papilla into the ureter through the callus. Where are you? Called papillary necrosis. Not a good thing. So, the scarring of pyelonephritis, pyramidal. What's that mean? That entire section. Then you have an ascending E. coli. I just gave you the patient. Who is your patient? Maybe perhaps a pregnant woman, putting a lot of pressure on the urinary bladder, making the urethra even more welcoming to the E. coli. Here comes ascending infection. Up it comes. Where is it going to then cause damage? Up in the papilla. You highlight in your head ducts of the papillary surface. Let's move on. You have necrosis taking place. And this necrosis of where? The papilla. What is this junction exactly? It's called the pelvico-calyceal system. What does that mean? That means that the pelvis is then combining with your calyceal system. What's my calyx? Major myelocalyx, right there. And so therefore, it can behave like a stone, especially when there's necrosis. So some of that mass that you're going to form with the renal papillary necrosis may then behave like a renal stone. Have you known a patient as such? You will, if you haven't already. How often is urinary tract infection? Quite often. So you want to keep those things in mind. All we're doing here is taking the anatomy that you've seen before, a little bit of physiology, mix it up with a little bit of microbiology, and you come up with pathology. So what is pathology? It's a huge cooking class. You're taking all these different ingredients, you're putting it in, and you come up with your dish. In this case, urinary tract infection. Yummy. Let's move on. Loss of papilla. What else may happen? Sickle cell disease. So if it's sickle cell disease, what's my issue? It's homozygous. Tell me more. More likely in what kind of population? African. Good. What else do you want to know? Sixth position. What happens? Glutamic acid replaced by valine. Good. Keep going. And with sickle cell disease, homozygous SS is what you have. Homozygous S and S. Wow, what happened? RBCs, now we're going to get sickled, especially when there's a little bit of stress, huh? And then what happens? I told you earlier that if there is such ischemia taking place, that what part of the pyramid and the nephron is susceptible to ischemia? It is your medulla. So, here, not urinary tract infection, sickle cell disease. Therefore, loss of papilla also might find issues. Everything that we just talked about is going to come into play because when you hear the term isotenuria, that is not a good thing. What happened? Close your eyes. Come through the glomerulus. Where are you? A Bowman space. Tell me about osmolarity. 300, approximately. Keep it simple. What's 300 mean to you? It's equivalent to plasma osmolarity, approximately. Isotonic. Okay? Where am I? Bowman space. Continue. You're going through the PCT. You're going through descending limb. What should happen normally? You're reabsorbing what? 2/3 of your water. What's left behind in the nephron? Solute. What happens by the time you get down to the medulla, the loop of Henle? What happens there? You remove the water. It should become what kind of urine? Hypertonic, 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 meaning what? Greater than 300, the urine. Osmolarity. Maybe 600, maybe 800, maybe 900. Whoa, could potentially get them to 1200, right? What's normal? Isotonic? 300. What if you have sickle cell disease and you lost a function of your medulla? Are you able to properly concentrate your urine? Read this. Nope. So therefore, if you're not able to properly concentrate because the medulla isn't working properly, my urine might actually be isotonic and down in the medulla. That is not a good thing. This is a pathology. So the fact that you have isotenuria means that you've lost ability in the medulla to properly concentrate that urine. Does that stanza make sense to you now? How significant is isotenuria? Quite. We'll talk more about that later. The kidney no longer able to concentrate or dilute the urine. It's lost its function. Where? Medulla. Let's move on.